Welcome everybody to this session, this breakout session, MBQIP 101. All sessions are being recorded. If you're having any technical difficulties, please let us know in the chat. Either I'll help you or there is somebody in the room from Perform Media that can help as well. We encourage your questions and interaction with the presenters. For questions during this breakout session, you may type a question by using the chat or verbally ask a question. To ask a question verbally, click on the icon labeled participants at the bottom center of your computer screen. At the bottom of the window on the right side of the screen, click the button labeled raise hand. The moderator will then call on you to ask your question, which you can do by unmuting your microphone. When you're finished speaking, please remember to remute to avoid background noise. So just to reiterate, the learning objectives for this session are to be able to recognize the purpose and importance of critical access hospital and state flex program participation in MBQIP, differentiate the roles of various players in implementing MBQIP, including the Federal Office of Rural Health Policy, state flex programs, the Rural Quality Improvement Technical Assistance or Arkita team, and more, and identify MBQIP resources and available support. So we have two of our friends from the Arkita team here to talk with you about MBQIP today. Sarah Brinkman joined Stratus Health as a program manager in 2016. She has more than 14 years of experience working in healthcare quality, ranging from the community to the national level. As a certified professional in healthcare quality, Sarah supports a variety of healthcare settings in understanding their respective quality reporting programs, making sense of their quality data, identifying opportunities for improvement, and implementing improvement strategies. She serves as the program manager and quality improvement specialist for Arkita and leads the quality payment program small, underserved, and rural support work. Sarah also supports Stratus Health's health equity focused work, including the Culture Care Connection website. Sarah earned a Master of Arts in Management and Master of Business Administration from the College of St. Scholastica, where her studies focused on healthcare and organization development. And we also have Robin Carlson. In her role of Quality Reporting Specialist at Stratus Health, Robin Carlson has worked closely with Minnesota Critical Access Hospitals, providing education on measure specifications, clarifying data abstraction questions, assisting hospitals using the CMS CART tool, and supporting the process of data submission to the CMS clinical warehouse. Robin worked with the University of Minnesota Rural Research Center to develop a data collection guide for the EDTC measure. As a member of the Rural Quality Improvement Technical Assistance team, Robin now expands the work she has done in Minnesota to assist critical access hospitals across the nation. She has developed an MBQIP quality reporting guide and has a set of abstraction training videos to help those new to abstraction and reporting. Robin received her degree in health information management from the College of St. Scholastica in Duluth, Minnesota. All right, and I will turn it over to you guys.
Great, thanks, Nicole. And Ari, I do see the option for me to launch the polls now, so I think we should be all set on that front, but we'll kind of play it by ear. So hi, everyone. I hope this finds you well for whether it's mid, late morning or early afternoon, wherever you are. Robin and I, some of you are familiar, are pretty informal presenters. We want to make this as useful for you all as possible. So we're going to do a little bit of an introduction just to kind of build on what Nicole just shared, and then we will have some polling questions to kind of help drive our discussion today. So Nicole reviewed our objectives. They're written out here in the slides for you, but it's the same as what she just shared with you, so I won't reiterate that. For those of you that aren't familiar, our team gets referred to in numerous ways. Sometimes people will say Arkita, sometimes people will say Stratus Health. We are one and the same for the purposes of MBQIP and the FLEX program. So Stratus Health employs Robin and I and the remainder of the Arkita team, which includes Carla Wang and Laura Grangard Johnson, Jody Winters, and then Mark Benjamin is our communications guru. Stratus Health is an independent nonprofit based in the Twin Cities metro area in Minnesota. And we really work at the intersection of research, policy, and practice. So we are not a research center. We are not a policy shop. We do not provide direct services, but we work at the intersection of all of those areas with regards to healthcare quality and safety. And Stratus Health serves as the Rural Quality Improvement Technical Assistance Center, or Arkita, through a cooperative agreement with the Federal Office of Rural Health Policy dating back to 2015. So this is our 5th year serving in that capacity. And our kind of goal and our task in that work is to improve quality and health outcomes in rural communities by providing technical assistance to beneficiaries of the F4HP quality initiatives, including FLEX and MBQIP, which is what we're going to focus on today, as well as the small healthcare provider quality improvement grantees through the community-based division of F4HP. So you may have some grantees of those in your state that you're familiar with, and we work with them as well. So I'm going to go through these next 3 slides just to get so you can be familiar with the 3 polling questions that we're going to be asking you, and then I'll launch the polls and we'll kind of talk about, get a sense from you all of what you would like to discuss. It looks like we're a relatively moderately sized group. We've got about 40 people on, so we should be able to kind of have this be a discussion and make sure that you get as much out of it as you'd like to. So in terms of getting to know you, we have 3 polling questions. We want to know, what's your role in implementing MBQIP within your state? Are you responsible for implementation of MBQIP? Is someone else on your team responsible for implementation, or do you subcontract implementation to another entity? So that's the first question. The second question is, how long have you been a part of your state FLEX program? So are you a newbie and it's been less than 6 months, 6 to 12 months, a year or 2, or more than 2 years? I realize that we've truncated those timelines significantly from what task asks you when you register, but really for the purposes of MBQIP, we're trying to get an understanding of how long have you been around, so we can kind of know what your familiarity with the program is. And then the third question is, of the following, which area of MBQIP are you most interested in exploring today? The purpose of the program, like why are we doing this work? Roles and responsibilities within the program, abstracting and reporting, data analysis, quality improvement, or general resources. So I'm going to go ahead and launch the polling questions, and you should be able to see all 3 of them at once. So we'll give you some time to go through and select your options there. Is everybody seeing the polls? Great, I'm seeing responses come in. I think that means it's working. Just give it about 15 more seconds here. That'll be a full minute, and then we'll wrap up the poll. Okay, so I'm going to go ahead and share the results, and hopefully you can all see the results on your screen. So we have a pretty good split, actually. We're about a 3-way tie in terms of what your role is. Some of you are subcontracting, some of you are the person responsible for it, and some of you have someone else on your team at your state FLEX program that's responsible for implementation. So it's nice to have that mix, and we hope that you'll weigh in and kind of share as we're talking about different approaches and different things that you've heard based on the role that you play in MBQIP implementation in your state. Most of you have been with the program for more than 2 years, which means you're likely relatively familiar with MBQIP. Robin and I offer orientation calls with new state FLEX staff related to the program. We have our MBQIP virtual knowledge group calls that we host on a roughly bi-monthly basis. So hopefully it's familiar to you all. For those of you that are newer, we've got a couple newbies. Please don't be scared if you haven't done your orientation call with us. We're happy to connect with you. It can be really overwhelming. Healthcare in general has a lot of acronyms, and then when you throw FLEX and MBQIP into the mix, it can become just a literal new language that you have to learn. So don't be overwhelmed. There's no such thing as a stupid question. And please do speak up and don't hesitate to reach out to us afterwards. As far as what you're most interested in talking about, quality improvement. Go figure, you're in the MBQIP session, so quality improvement makes a lot of sense. I think what we'll do, since it's a pretty even split between kind of the data analysis and quality improvement and those types of things, general resources, we'll flow through the slides. When we get to quality improvement, we can slow down a bit and ask for some more input from all of you about the types of resources or things you're specifically interested in. So please do use that raise hand option. Please weigh in on the chat. We want this to be as interactive as possible so that you all can get what you need out of it. So high-level overview, MBQIP as part of FLEX. You know that within FLEX you have a variety of different activities that you are either required to have written into your grant or that are optional, and quality improvement is one of the required activities under the FLEX grant. And it really is focusing on improving the quality of care that's provided in critical access hospitals, first by increasing the quality data reporting and then driving improvement activities based on their data. Since MBQIP launched, MBQIP basically kind of took over the quality improvement activity under FLEX. So it's one of the really standardized ways that F4HP has been able to kind of implement FLEX. You still have flexibility in terms of how you implement MBQIP, but MBQIP is essentially a requirement now. Whereas before MBQIP existed, states could be doing a variety of different quality improvement activities, and that was wonderful, but F4HP wasn't really able to take that and roll it up in a meaningful way to show a national impact. So that's a really important point to capture in terms of the purpose of the program. The goal here is that F4HP works with partners, including all of you, to identify rural relevant hospital metrics, and then provides technical assistance, encouragement, and support through their various subcontractors and cooperative agreements, including the one with Arkita. And they work as hard as possible to align with other federal quality programs. And there's a few reasons for that that we'll talk about as we kind of go through what are the benefits to cause. So really at a high level, the idea is we use that common set of rural relevant measures to measure quality, use the data from that quality measurement to improve quality, and then the ultimate goal is to improve patient outcomes. Secondary to that, and all along, has been this notion that we're really working towards helping critical access hospital prepare for value-based reimbursement. So prospective payment system hospitals were initially offered the opportunity to voluntarily report their data. Then the CMS started to pay for the reporting of the data. So if you reported, you got paid. Then they started to pay based on the performance in the data. And more recently, they've been moving more towards these alternative payment models. Because of the way that critical access hospitals are paid by CMS, they've never been required to participate in the CMS quality reporting programs, but they kind of have they've jumped over that voluntary, well, they had the voluntary reporting, but they jumped over the pay for reporting and pay for performance and went right into alternative payment models. And so that could be a really kind of tenuous place to be. And so MBQIP was an opportunity and provides an opportunity for hospitals to participate in that kind of demonstrating quality through a quality reporting program and kind of fill that gap from voluntary reporting through CMS to alternative payment model arrangements and really be able to build their capacity in the meantime for demonstrating the quality of care that they provide. So some of the benefits, obviously improved patient care and quality outcomes. Nobody gets into healthcare people get into healthcare because they want to do well by their patients. And so ultimately we all have that shared goal of wanting to improve patient care and quality outcomes. Critical access hospitals that participate in MBQIP have the ability to compare their performance against their counterparts, both within their state, nationally across critical access hospitals, and then also against their prospective payment system hospital peers. Because many of the measures are aligned with federal quality programs, we can look not only at how an individual CA is doing, we can look at how all the CAs in a state are doing, all the CAs nationally are doing, and how they're doing in comparison to PPS hospitals. And in some cases, critical access hospitals have a lot of opportunities for improvement, and in other cases, they're doing a lot better than their PPS counterparts. And so that's really helpful for them. And we hope that in time, as states are able to move beyond just building the capacity for quality data reporting and the basic analysis, that they can start to help their hospitals leverage that data to make the case for why they should be the provider of choice for their market share. Again, I talked about increased capacity for participation in federal reporting programs. Ever since MBQIP started and since the ACA was passed, there has been this kind of idea that eventually CMS is probably going to flip a switch and say, okay, critical access hospitals, you're no longer exempt from quality reporting. We want them to have the capacity to meet that requirement should it ever come. But in the meantime, it does provide them the opportunity to, again, do that comparison data, but then also be able to meet quality reporting requirements or desired quality reporting for third-party payers. And finally, F4HP recognized that they weren't paying critical access hospitals to participate in this program the same way that CMS pays PPS hospitals for their quality reporting programs. So they gave a little carrot and stick and said, hospitals need to meet minimum quality reporting requirements on an annual basis in order to be eligible to access the full scope of other flex resources that are available to them. So if you're doing things like financial and operational improvement or population health or EMS related projects, your critical access hospitals have to be meeting those minimum MBQIP reporting requirements on an annual basis or working very closely with you through a waiver process to build their capacity to meet those requirements in the future. Those requirements were waived this year in part as a recognizing the impact of COVID-19 and not wanting to restrict access to flex support for any critical access hospitals during this time, but those requirements do get updated typically on an annual basis, and F4HP has continued to raise the bar on what's expected for minimum reporting. So as we jump into implementation, we're going to talk about some of the different players. So F4HP, the state flex programs, we at Arkita, our friends at TASC and at the flex monitoring team, and then of course critical access hospitals. F4HP, this is their program. It's actually their project. It's the Medicare Beneficiary Quality Improvement Project. So MBQIP is a project within F4HP. They identify the measures and they set the eligibility requirements. What I really like to point out here is that they don't do anything in a vacuum. They're always looking for input. If you've participated in any of the refresh related calls, recently that F4HP has hosted or has presented on, you know that they want to hear from you. What's going well, what could be going better, how can they make this program as meaningful to you all at the state level and to your hospitals as possible, while recognizing the need for being able to demonstrate the level of impact at a national level as well. They're responsible for distributing the quarterly MBQIP data reports to you all, which then you can turn around and do further analysis or directly redistribute to your hospitals. They organize learning sessions and share relevant resources, provide support to you all, and then they work to build relationships with partners. So you're all familiar with TASC, Arkita, and FMT. We all are funded through F4HP. So obviously have a very vested interest in developing relationships and maintaining those relationships with their funded entities. The more important ones, I think, are their relationships that they've really worked to foster over the last number of years with the Centers for Medicare and Medicaid Services and the Centers for Disease Control and Prevention, and really advocating for those two national entities to recognize the importance of rural relevant measures and carving out a space for critical access hospitals within their quality programs so that we can not only be able to help critical access hospitals improve their care, but demonstrate the value that they provide to the populations that they serve. So you all at the State Flex program obviously have a large role to play as well. You're responsible for collecting MOUs. For the most part, that work has been done for you at this point. If you weren't the one who had to go out and get them, be grateful for the person who came before you. They don't have to be updated on an annual basis or anything like that. Once they're in place and you're good to go. So really 99% of critical access hospitals nationally are participating in the program, meaning that they've signed MOUs. If you have a hospital that converts from PPS to critical access hospital status, or if somehow you have a brand new facility opening, this would be something that you would be responsible for doing. More so beyond that, getting the MOUs, your primary roles are around monitoring and assisting the hospitals with their quality reporting. And for those that don't meet the minimum participation requirements, working with them to build that capacity through the waiver process, supporting quality improvement initiatives, which we'll talk more about, engaging other quality partners in the state. There are a lot of different quality initiatives underway. Some that you might be familiar with would be around like the Quality Innovation Networks or QINQIOs. What used to be the Hospital Improvement and Innovation Networks and will now going forward be called the Hospital Quality Improvement Contractors, or HQIC. It used to be HIN, it was HEN before that, lots of acronyms. There's lots of opportunities for critical access hospitals to be involved in quality improvement work, and as much as possible, it's nice to be able to align those efforts and collaborate with those partners in your state to make it clearer for the hospitals what they're participating in and how to get support. And then providing feedback to F4HP and their partners, including Arkita and TASC, regarding program and resource needs. Our role at Arkita is really to provide, first of all, you all at the state flex programs with support, and then your critical access hospitals as well, by providing education, resources, and individual technical assistance. And kind of our key areas of expertise are around data collection and analysis. Robin Carlson is our data collection and measure specifications guru. If you haven't connected with Robin, you should, because she's kind of a walking encyclopedia of how the measures are collected, what they mean, what the hospitals need to do to get the data into systems and things of that nature. And then Laura Grangard Johnson is our data analyst, and she creates a lot of great resources for you all to be able to take the data that you receive and make sense of it. We work closely then with partners at the Flex monitoring team and at F4HP to work on benchmarking and target setting for you all, both at a national level, but we're also available to talk to you at a state level about what makes sense for your particular set of hospitals. We develop quality improvement skills and tools, developing and implementing efficient and effective improvement strategies, and then helping to track the outcomes of your quality improvement efforts. TASC supports state flex programs with alignment across all of the program areas, including MBQIP, and we work very closely with the team at TASC. So we are not meant to be in any way, shape, or form a replacement. We're kind of a supplement, and we kind of dig into that quality improvement work specifically, but we're in constant contact with them. So as you're thinking about overall flex implementation, things that might come up if you're among that group that subcontracts this work out would be, how do you work with your subcontractor? We certainly are happy to talk to you about that at Arkita and share with you what we know, but the folks at TASC are really the experts when it comes to helping you understand how to best manage your subcontracts for flex. They host all of the MBQIP resources on their website. So you have a one-stop shop for all things flex related. And then they also host the Flex Forum, which we really encourage states to utilize as much as possible. It's a really great opportunity for you all to reach out to each other and ask questions. We can help make those individual state-to-state connections, but it's really based on what we know about what's happening in each of the states. If you've posted in the Flex Forum, I guaranteed almost every time someone's posted something out there, we learned something new about a state that's doing something innovative that we didn't know about. So that is a really great resource. I saw that Megan's on the call. So we've got our partners at the Flex monitoring team. They are now responsible for developing the quarterly hospital and state level data reports. Your first rounds of those reports coming from them will be over the next 6 months or so. We're really excited to be working with them directly on that. They also develop the annual state hospital compare reports. They manage COMPASS, the CA measurement and performance assessment system, where you can explore HCAPs and hospital compare data for your cause. And their link there, the flexmonitoringteam.org, is available. And there's also a hyperlink to COMPASS directly. And then your critical access hospitals, we couldn't do this without them. They're hugely important. This program is theirs, really. So they're reporting on the measures. They hopefully are reviewing the data reports that you provide them. Some of you just provide, some of you provide the reports that are shared by F4HP. Some of you do additional data analysis. Some of you are doing real-time data collection. They just came off of a session with Nebraska and Illinois where they were talking about how they're getting the data in more real time from their hospitals and providing dashboards. So there's a lot of different ways that this is done in terms of sharing the data with them and then what the hospitals can do in terms of analyzing those reports. Identifying and pursuing opportunities for quality improvement. So hopefully they're reaching out to you and recognizing that it doesn't have to be just something that you are doing for them, but that they can ask for things as well. They might be participating in your state-sponsored MBQIP activities. Some states do quarterly calls with their quality contacts. Some states have cohort approach to improving performance on specific measures or a regional approach. It really differs. Some states have 80 plus CAs and some states have 3 CAs, so it really is a mixed bag. And then hopefully they're providing feedback to you all and you're giving them an opportunity to provide that feedback regarding quality reporting and improvement support and resource needs, and including what measures do they feel like should be part of MBQIP that aren't? What's something that they feel really strongly they should be working on, and maybe it's not, we're not collecting that data currently for some reason. What are our opportunities for further developing the program to make it as meaningful as possible for them? So now this is the part where I'm going to stop talking and let Robin weigh in. Is there anything, has anything come in over chat or any questions that anyone has at this point?
I haven't seen anything on the chat.
Okay. Well, we'll keep trucking along then. Go ahead, Robin.
Okay, hi everyone. This is just so you don't have to know how to collect these measures, but you have to be well aware of when you've got someone talking about the core measures. The core measures of the MBQIP program, these are the current measures. If you've been around for a while, you'll see that there's not very many anymore. They are listed here under domains. The program and FORHP talks about the different domains: patient safety, inpatient, patient engagement, care transitions, outpatient. But sometimes when you're down on the hospital level, the abstractor level, which is kind of where I live most of the time, we talk about the measures, their names. You know, whether it's like OP2 or OP18, sometimes the hospitals aren't really aware of what the domains are. So this will just give you an idea as if you might be saying domains and these are the measures that fit under them. So under the patient safety inpatient, the only ones that are left now is HCP, the healthcare personnel influenza vaccination. It used to be called OP27. That was when CMS had it in their outpatient reporting program. They removed it from there. The measure was the same. It was just called HCP and inpatient, OP27 and outpatient. The IMM3 is how it's called on Hospital Compare. So it's just to make everything really difficult, but it's the same measure and it's collected the same way on the same population. So it's healthcare personnel influenza vaccination. And then the antibiotic stewardship for the program right now for MBQIP, how hospitals collect that measure is when they fill out the annual facility survey in NHSN. Under patient engagement is HCAPs. I don't think I have to really say much more about that. Everybody has a lot of opinions about HCAPs, but that is the measure under patient engagement. Care transitions are the EDTC Emergency Department Transfer Communication Measure. It's the one set of measures that's not collected through CMS or NHSN. These are the measures regarding your patients that were seen in the hospital's ED and then transferred, discharged, returned to other healthcare facilities. These are the ones that they get, the hospitals collect, and it gets sent to you at your flex offices, and then it gets forwarded by you or your contractors to FORHP. The outpatient measures, these are CMS measures, okay? The program has chosen these out of the CMS measures. There's the AMI measure set, the 2 measures that fit in there, OP2 and 3. And then the ED throughput measure set, OP18, and then OP22 is a measure that only gets collected yearly. The other measures here under outpatient are collected quarterly. This is a really good visual of where the the measures get reported to. The blue here, quality net. So those are the CMS outpatient measures, the EDCAP survey data, whether the hospital does it themselves or a vendor does it, that gets submitted to quality net. And then OP22 measure, that's also submitted to quality net. It's kind of has in a different little box because again, that's only submitted once a year, where the others are quarterly. The orange is NHSN, the National Healthcare Safety Network. So that is where the hospital is going to submit their healthcare personnel data. It's submitted once a year. And then the antibiotic stewardship, and right now that's submitted via the annual facility survey that again gets done once a year. And then the state to you guys go the EDTC measures. Before I talk about additional measures, is there anything in the chat that's about the measures I just spoke of?
I'm not seeing anything about the measures you just spoke of. The comment that came in was from Jill with regards to the EDCAP. So Jill, we saw that last week too. CMS updated their webpage. They used to have what was called the EDPEC, which was the Emergency Department Patient Experience something. I can't remember what it was. Most of us are familiar with CAPS, and CAP stands for Consumer Assessment of Healthcare Providers and Systems. So there's HCAPS for hospitals, OAS caps for outpatient and ambulatory surgery, CG caps for clinicians and groups. And there's been a lot of talk amongst flex programs for a long time about the desire to have some sort of a patient experience survey, and you can see that under the patient engagement additional measures here related to emergency department, because your volumes are much higher in your EDs than they typically are in your inpatient. I don't have the screen pulled up in front of me because I'm sharing my screen with you right now with the slides, but I think what you'll see, Jill, if you look at the EDCAPS page that you shared, which is a great opportunity for folks to go out and check that out, they have launched or shared the revised survey. They do not have a mechanism in place for collecting that data. So it isn't data that hospitals can submit in any standard sort of way, or any way really, to a federal entity. There is a standard survey that's available, but we don't have a way of collecting the data to compare it at this point. So we are tracking on that closely, and I'm sure the folks at F4HP are as well. That's really kind of hot off the press, and it came in a little under the radar. We happened to fall across it. We check every once in a while just to see what's going on, and oh, they changed the page. So it is now being called EDCAPS. So I'll let Robin talk a little bit about the additional measures here.
Okay, the measures that I was just mentioning, those are the core measures for the MBQIP program. Those are the measures that your hospitals should be submitting and should be continuing to improve on and do quality improvement on. Now, if you're in a situation where your hospitals are doing great on all those measures, their percentages are high, you know that they're accurate, these might be additional measures that you want to work on. Maybe there's an interest with some different entity in your state that's having a program or starting something on one of these measures, or you've got certain hospitals who are interested in these measures, but they aren't, they shouldn't be done in lieu of making sure your hospitals are doing good on the other measures. These are additional ones that you can maybe write into your program of what you want to do in the next year. But again, and these are, a lot of these, you'll note, I think a lot of people think that maybe they have to do these or they don't have a good understanding, but a lot of these are, they're called measures, but they might not really have a way to be measured per se. If you look under patient safety inpatient, there's the healthcare associated infections. Well, those can be submitted into NHSN, but other ones here for like falls or inpatient influenza immunization, they don't have a way to be measured, but they might be something that your hospitals, again, are interested in working on, or you were interested in working on these with them. But again, additional, you know, as long as they're doing great on the other measures.
Yeah, the one quick caveat I would throw out there is that with FMT taking over the development of reports going forward, and maybe Megan can weigh in and chat, the HAIs, the Healthcare Associated Infections, that is data that if your hospitals are reporting into NHSN that FMT has access to, and so they'll be developing an additional measures report with that data. Some of the others that Robin mentioned, like inpatient influenza immunization used to be a CMS measure. It's no longer a CMS measure, so there isn't a standard way to collect that data federally. But if you wanted to work on it at a state level, you could figure out a way to have your hospital submit data to you. Similarly, kind of across the board on these others, the ED patient experience, retired measures for chest pain and AMI or emergency department throughput, things that you were working on before. So I want to be cognizant of time. I know we're running a little long here. This is just an overview of what's happened with measures since MBQIP's inception. So you can see that as CMS kind of analyzes the data that they receive, they retire or remove measures from their program. And once a measure has been removed by CMS, there's no longer a mechanism for standard collection at a national level. So all of those that are grayed out are measures that CMS removed. And so they were no longer available to be a part of MBQIP. And you can see we're kind of getting down to some bare bones in terms of what's available to us currently. I want to review a few resources. We'll kind of go over these quickly because I want to pause and see if there are questions. All of the resources for MBQIP are posted again on the task webpage, and the link is provided there. They're broken down into kind of different areas of interest. So there's state flex program key resources, general quality improvement, data reporting and use, care transitions, outpatient, patients engagement, and patient safety and inpatient. Those last four are the domains, if you will, of MBQIP. And so that's where you can find specific information about improvement on those measures within those domains. If you're looking for anything about data reporting, you'll find it within that data reporting and use section, regardless of the measure or domain that it falls in. Some of the key resources that we would hope that you all are familiar with, and if you aren't, we'd encourage you to go take a look at. The MBQIP Fundamentals Guide for State Flex Programs is really meant to be kind of your catch-all for MBQIP and implementation at the state level. It's organized in such a way that the resources that are available to support the program are built into the resource and kind of given some context so that you can understand how and when you might use some of those resources. MBQIP Monthly went out this morning. Hopefully you're all sharing that with your hospitals. We typically send that out the first full week of the month. And it's our only really direct way of communicating with the hospitals. So we can't stress enough how important it is for you all to share that with them. It's the way that they can find out about Robin's quarterly office hours calls that she hosts. It's how they can learn about other hospitals that are doing really well in MBQIP and how they're doing that. It's where they can get tips and tricks for abstracting and reporting or data analysis. It's also how we're promoting our new quality time sharing pie podcast. And we want to make sure that you all know that we are available to provide presentations and education to your hospital. So that's the last bullet point there around Arkita presentation topics. It's not an exhaustive list, but there is a list out there of some ideas of things that we've done for other states in the past, and a form that you can submit to request someone from our team provide a webinar, or when COVID-19 is over, an in-person presentation if you would like to have us come out. We host virtual knowledge group calls for you all roughly on a bi-monthly basis. Our next call will be August 20th. So the hyperlink here will take you to a registration. These are for state flex programs and their subcontractors only. Please don't invite your critical access hospitals. The content isn't geared towards them. It's really geared towards you. So we hope you'll join us on August 20th for our next call. Some of our quality improvement resources that we would want to call attention to, again, MBQIP Monthly is how we share success stories from hospitals that are performing really well on MBQIP. It's also how we share our newest resource, which is our Quality Time Sharing Pie podcast. Our second episode just dropped with the sharing distribution of MBQIP Monthly this morning, so please check that out. We have a quality improvement basics course and a facilitator's guide that goes along with that that you can use with your hospitals if they're interested in kind of getting back to basics around quality improvement. And then that top resource there is our quality improvement implementation guide and toolkit. Within that toolkit, there's an MBQIP best practices list that goes through the core measures of MBQIP and provides some suggested best practices for improvement on those measures. There's lots and lots of reporting resources. Probably your best reporting, not probably, your best reporting resource is Robin. But we've tapped into Robin's brain and tried to get some of what she knows onto paper. So these are some of the ways that you can learn more about quality reporting. We put together monthly data reporting reminders. Robin has done some recordings. So there's a training series available. She hosts her quarterly open office hours that is really meant for critical access hospitals. Of course, you all are welcome to join that as well, but that's an opportunity for them to ask her questions directly. And really importantly, we want to call attention to the opportunity for abstracting for accuracy. So when you think about how the data flows, hospitals report the data, you get the data back and you analyze it, it felt like we were missing a step in the middle there to make sure that what they're reporting is accurate. So this is an opportunity for them to work directly with Robin and make sure that that's the case. So we really encourage you to check out that opportunity for your hospitals. And then there are, of course, data report resources for analyzing and making sense of the data, and measure-specific resources. Many of the measure-specific resources that are on the MBQIP page are developed externally. We just called attention to some of those that were developed either by our team or by the team at Task. All right, sorry. 45 minutes is not a very long time to get through all of that. So hopefully we have, I don't even know if we have a minute left for questions. Anything come in through the chat?
Nope, I don't see any questions in the chat, just lots of compliments about how Sarah and Robin rock. Did anybody have any questions? You guys, you have 1 minute to go ahead and unmute your microphone and ask. Otherwise, I will close us out. Oh, look at me getting compliments too. Thank you, Kyle.
Can I just say quick one thing? I think, you know, for a lot of you, you don't have to know how to do abstraction. If you're there and you've got your hospitals all of a sudden talking to you about, you know, really deep into the measures, you don't have to know that. But that is one thing that I can really help you on. You know, you need to be able to know what the measures are, and your hospitals have to come to you about, you know, what the requirements, quote unquote, are for the program. But you know, I can help them with the ins and outs of the measure. And I think a lot of them get so frustrated because they don't know who to come to, and CMS resources are out there, but they're not labeled under MBQIP. And if people haven't been part of the program for a long time, they're not sure what to do. So, you know, always know that I can try to help you with your hospitals and that piece of it.
Thanks, Robin. Okay, we are out of time. So now we have a 10-minute break. We'll reconvene at 1:15 Central Time for our closing keynote session, which is titled Seeing 2020 Experimentation, Innovation, Opportunity. I believe a link will show up here in the chat. Otherwise, you can find that in the portal on the website. So that's it. Thank you, everybody. Have a good day. We'll see you in the closing session.
Thank you very much.